Hello, my name is Charlotte Kline. I am a Doctorate of Nursing practice student at Maryville University, and today I'm going to be talking about my scholarly project, and it is titled Reducing Stress Through Therapeutic Music in the Adult Psychiatric Population. Here on this slide is the committee for my project. It consisted of Dr. Hepner. She's the DNP chair for the project. She provided a lot of feedback throughout the project from the beginning planning stages to the completion of the project, and her help was very valuable. Dr. Lisa Struer, the second reader, and the faculty for Nursing 707, and also Courtney Loy, who is the community member for the project and also works at the facility where the project took place as a nursing manager, and also provided a lot of valuable help throughout the project to myself. Okay, to start with the background of the project, a little bit of background about where the project took place. It took place at a acute psychiatric facility in the Pacific Northwest. The specific unit where the project took place was the Psychiatric Emergency Department. This department is a short-term crisis stabilization department. Patients stay in an open milieu in reclining chairs anywhere from a few hours to 100 hours at most. The issue that the project really spawned from was that there's a lack of activities for patients to participate in, and very few interventions and distractions from stress. Patients are able to watch TV, draw, journal, talk to each other. There are very few group therapy activities that happen, and aside from that, there really isn't much for patients to do. So that was the initial issue that spawned the project idea. The aims of the project are helping patients achieve stress reduction. And stress reduction is very important because stress is a main contributor to psychiatric symptoms. Psychiatric symptoms can be defined as anything from anxiety to agitation, can sometimes result in violent behaviors. So reducing stress reduces psychiatric symptoms, and this can reduce unwanted outcomes. There are dangerous conditions that can be experienced in psychiatric facilities. These can include violence, and these can lead to patients being placed in seclusion, placed in restraints, given medication above their objection. And this is ultimately traumatic for patients and staff and leads to major safety issues. So the root of this is that reducing stress can hopefully reduce some of the occurrences of these downstream issues that can result from too much stress and exacerbated mental health symptoms. Okay, so a thorough review of the literature was conducted to support the project. And in the literature review, there were 4 main themes that were explored. The first of these themes is stress, which is the main root of the issue relating to this project. Increased stress is associated with exacerbated mental health symptoms, and decreased stress is associated with relief from psychiatric symptoms. Increased stress is associated with poor outcomes such as violence, restraint and seclusion, involuntary medication administration. So the consensus of the literature review as it pertains to stress is that reducing stress is an important aspect of improving care at psychiatric facilities and for psychiatric patients in general. The second main theme that was explored is the psychiatric patient population, and the literature review revealed that this patient population is not researched adequately, and this is likely due to the population's status as a protected patient population and a vulnerable patient population. However, the result is that there is a lack of new evidence coming out compared to in other areas of medicine, because there's a lot of liability associated with conducting research in this population. And this lack of research ultimately serves as a barrier to providing patients with evidence-based care and with the best care possible in psychiatric facilities and in general in outpatient settings as well. The third theme that was explored is music. Music has been used in a variety of settings and has been observed to be a good tool for stress reduction. Some of the settings that I read about in my literature review were dental offices, outpatient surgery, even like oncology units. So music is very versatile and has been used in a lot of different settings to help with stress reduction. However, as discussed previously, it has not adequately been explored in the psychiatric hospital setting, which is very interesting because stress is a main contributor of mental illness and mental health symptom exacerbation, but yet music has not been properly explored in this setting. So there's definitely a need for more research there. And then the fourth theme that was explored is self-assessment. The literature review revealed that stress can be measured in a variety of different ways. Objective physiological findings like heart rate and blood pressure, self-reported symptoms, a mixture of both. So it was ultimately decided that self-assessment would be used to measure the degree of stress reduction for the project. And the specific tool that was chosen to be used was the Perceived Stress Scale. And this is a 10-point questionnaire that asks the individual to report the frequency at which they experience specific symptoms of stress. And this tool has been found to be both sensitive and accurate. And it was decided that it would be appropriate for use in the project. Ultimately, the findings of the literature review were incorporated into the planning of the project and helped to form a foundation on which the project could be designed and built and ultimately executed. Okay, so the theoretical framework that was chosen to support the scholarly project is called the Stress Adaptation Model. The Stress Adaptation Model uses the severity of symptoms to differentiate psychiatric patients into 4 stages of psychiatric crisis. The first stage is crisis. This is the first and most intense stage. This is when intervention needs to be taken rapidly because the patient is in a state of psychiatric emergency. The patient at this point is at risk for harming themselves, for harming others, and overall not being able to care for themselves. The second stage is the acute stage. This happens directly after the crisis stage. During this stage, interventions have been initiated or the initial crisis has subsided. The patient is potentially hospitalized at this time. The symptoms are still severe enough for the patient to need to be in the hospital, but the patient is improving and working towards resolution of their symptoms. The third stage is the maintenance stage. At this point in time, the patient is somewhat stable, a lot closer to their baseline, and ready to return to their normal life. The patient will still need time to adjust back to normal life, may need to take more time away from work or other responsibilities, but doesn't necessarily need to be monitored or have interventions applied constantly. So the fourth stage is the health promotion stage, and this is the stage where the patient is thriving. They're doing well, they're able to focus on making long-term improvements to their health. A lot of patients in this stage will volunteer or serve as peer supports to others who are in crisis, which can be very beneficial both to the patient in the health promotion stage and the patient in the crisis stage. So the facility where the project took place cares mainly for people who are in the crisis and acute stages of the stress adaptation model. These are the highest stress stages of the model and are associated with the most intense psychiatric symptoms, and they're ultimately the most dangerous stages of the model. They're where the patient is most likely to cause harm to themselves or others. The goal of the project was to help people move through the stress adaptation model to work toward the health promotion stage, which could look like moving from a more severe point in the crisis stage to a less severe point in the crisis stage. This stress adaptation model takes a long time to move through, and it's a very gradual progression from one stage to the next, especially as you move from maintenance to health promotion. Okay, so getting into the method and design of the project. The type of project that was chosen to be conducted was a quality improvement initiative. Quality improvement initiatives take place with the goal of improving current practice to best support patient care. So the ultimate goal of the project was to improve patient care and experience on the unit where the project was to take place. The design of the project was a pre-test, post-test design, and the perceived stress scale was used as both the pre-test and post-test. The setting of the project was the Psychiatric Emergency Department, which has been described previously in this presentation, at an acute psychiatric facility in the Pacific Northwest region of the United States. The sample that was used was a convenience sample, and this consisted of patients who were already hospitalized on the unit where the project took place. They were selected by their primary nurse, who was assigned for the day, and they were decided to be either appropriate or not appropriate for participation based on inclusionary and exclusionary criteria. Exclusionary criteria mainly included history of violence, inability to ambulate, inability to complete a written questionnaire. Most patients were determined to be appropriate for participation in the project. After they were selected by their nurse, they were asked, a list was made of patients who were appropriate to participate, and those patients were asked if they would like to participate in the project. And they were notified that their participation would involve ambulating to a room adjacent to the main milieu area of the unit for the intervention to take place. The initial goal was to recruit 42 participants to complete the sample. However, the sample size ultimately was 18 participants, and this was achieved through 7 separate data collection sessions on different days over the course of about 5 weeks. So that all took place, and then the data was analyzed. The Maryville statistician was very helpful in this process. He recommended that a t-test to be run to analyze the data. The power analysis revealed a power of 0.0833, etc., which ultimately is a weak power. The significance found through the data analysis was 0.786, which is a weak significance. and the confidence level that was used is 95%. So ultimately, the results of the project were not statistically significant. And this is a visualization of the raw scores of the project. And they're shown in this paired line graph. And just by looking at the graph, you can kind of see that the results are a little bit all over the place. Some participants experienced a reduction in scores to varying degrees. However, others observed an increase and others observed no change at all. So even without really going into the data analysis, there's a lot of variation that can be observed in the raw data alone to suggest inconsistent results from the intervention, which ultimately is what was observed through the data analysis. There are several limitations that contributed to the lack of significant results observed in the project. The first of these is low interest. There was definitely less interest in participating in the project than what was expected. And ultimately, the majority of people who were asked to participate chose not to for various reasons. A second limitation is that there was some confusion expressed with the data collection tool. More specifically, patients expressed confusion about whether or not to report a short-term change in stress, which was not expected to be an issue. Because the tool has been found to be sensitive, it was thought that it would also be sensitive in this project. However, there was definitely confusion about the length of time patients should consider when reporting their stress. Another issue was the time of day. Many potential participants chose to nap rather than participate, which is likely due to the project taking place during the mid-afternoon each day during the time of data collection, and it's possible that if patients were asked to participate during a different time of day, they may have chosen to participate as opposed to sleep. Another thing to note is that psychiatric patients can be unpredictable, and results can differ from what was expected for no reason at all or for an unknown reason. Excuse me. A barrier is that the project took place in the summer, which traditionally speaking is a low census time for psychiatric hospitals. Sorry. Many patients in psychiatric hospitals are without shelter, which means that census at these hospitals is higher during the cold fall and winter months and lower during the summer months when not having shelter in the community isn't as much of an issue. And so this could have definitely contributed to the lower sample size that was observed and ultimately to the results. Facilitator is that both management and clinical staff were very supportive, both of myself in conducting the project and of the project itself. And there was quite a bit of excitement around it. So that was definitely a facilitator. Ultimately, the findings differed from what was expected. The results were not clinically significant, which means that no change in practice on the unit was recommended. There are several factors that were discussed previously that likely contributed to the unexpected findings of the project. And there is a need for future research into the use of music as a means for reducing stress in the adult psychiatric patient population. Furthermore, there's a need for research about improving psychiatric patient outcomes in general and improving the quality of care that this population is receiving. The problem that this project sought to address still persists, which means that more work needs to be done to improve the quality of care that this population is receiving. So while there were no implications for practice specific to the unit and the facility where the project took place. There are some greater implications that I will now discuss. More research needs to be conducted to address the problem and to improve care for psychiatric patients. This research should involve psychiatric patients because this is the most accurate way to determine how that specific population will respond to a given intervention. For healthcare policy, psychiatric patients are reporting that psychiatric hospitals are not providing therapeutic care and that psychiatric facilities are not conducive of healing and mental well-being. Thus, there are changes that are necessary to improve care for these patients so that they are not marginalized by healthcare. Some implications for quality and safety. Quality and safety is a huge concern for this patient population. It is a patient population that is associated with violence and adverse reaction or adverse events. And all of these changes will improve the amount of data available about this population for future quality improvement initiatives and scholarly projects. Okay, so although the results for the project were not significant and no changes were made, the project helped to reveal areas for growth and room for future research. If changes were made to the project based on the identified gaps and limitations, the results may have been different, and the hope is to see further improvements made to psychiatric care in the coming years through more research, quality improvement initiatives, scholarly work, etc. If anyone has any questions, this is my contact information. I am definitely available to communicate by email about the project and would be open to and happy to. And here are the references that were used for the project. The references that were used for the presentation specific to the project. Thank you again for listening. I really appreciate you taking the time, and I've really enjoyed sharing the project and my findings. And yeah, thank you.